May I call upon Dr. Sunit Karnaratna, consultant cardiologist, Teaching Hospital, Anuradhapura, to deliver the next plenary. The topic is patient and staff safety precautions during cardiac catheterization. Over to you, Sunit.
Thank you. Right, so we'll discuss why safety in the cath lab is important. Sometimes patients can suffer complications and physical injuries, even death, during or after cardiac catheterization. And most of them can be prevented by patient selection and pre-operative preparation and following the standard safety protocols. The same way, the staff can develop chronic health problems like radiation exposure and also back problems, and also there is a risk of physical injury in the cath lab. So if you follow proper safety protocols, this can be avoided. So when you look at the main safety concerns in the cath lab, one is, as you know, radiation, and then contrast-induced nephropathy, physical injuries, there can be medication errors in the cath lab, and there can be procedure-related complications. So first we'll discuss about the radiation safety. Radiation safety is mainly important for the staff. Sometimes it can be an issue to the patient if you do very prolonged procedures, which can cause skin burns. But it's more important for the staff because they are chronically exposed to the radiation, where we do numerous cases over the year, hundreds of cases. For example, in Anuradhapura, we have only 2 cardiologists, so one cardiologist will have to do cases for a week. So there will be a lot of radiation involved. Usually there is a radiation safety officer, usually it's a radiographer. He is in charge of radiation safety. So when you look at the cath table, usually the X-ray generator or the source is under the table, and there is an X-ray tube. There's a thing called collimator. Then you get the bed, on the surface of the bed, patient, and the radiation detector or the image intensifier is at the top. So the radiation we get is usually from the scattered radiation. When the radiation travels to the table and the patient's body, some of the waves are scattered by the tissues. So the staff get exposed to scattered radiation. Usually the staff will not be in the way of direct radiation beam. So when we talk about radiation safety, there are 3 major things. One is time. So if you reduce the exposure time, there is less radiation. And the second is distance. If you stay further away from the source, exposure is less. So if you increase the distance from the source by 2, the radiation exposure will be only a quarter from the original amount. And then you have to use shielding to block scatter radiation from the patient. So there are various measures you use to measure the radiation. One is the gray. Gray means amount of energy deposited in a material per unit mass. So 1 joule per kilogram of the patient. If patient gets 1 joule of radiation energy per kilogram of exposure, so we'll call it 1 gray. So there are many other units. So I'm not going to discuss about those units. Those are important because when you use personal dosimeters or radiation badges, it will be recording the amount of radiation. So you have to have a general idea what is the radiation. So it's actually the energy you get through radiation. That is the one which is measured. Right. So you have to wear the appropriate equipment. So you need to have a leaded apron. Especially you need shoulder pads for women because the breasts are radiosensitive. Leaded glasses are important because there's a risk of cataract, radiation-induced cataract. And lead thyroid collar because thyroid is also very radiosensitive tissue. And you can use all optional leg shields. They should be at least a quarter millimeter of lead in those shields. And proper use of dosimeter radiation badge. So usually there will be one radiographer who is the in-charge radiographer who should distribute radiation badges and who should also take them back at regular intervals and check how much radiation each staff is exposed to. So I don't think in many of our cath labs dosimeter badges are available, but they are not properly used. So it's the duty of the radiographers, in-charge radiographer in the cath lab, to streamline this and start doing it. At least they should start wearing dosimeter badge, then others will request for it. And then the table and image intensifier positions are also important. From the X-ray source, you should keep the patient at 70 centimeters. That is considered the optimal distance from the source to the patient. And you should try to maintain maximum possible distance from the image intensifier to decrease scatter radiation. Now, after we started, we do many of our cases. Now, most of our cases, I think about 95% of the cases are done through the radial access. One disadvantage of radial access is we have to stand closer to the patient than for the femoral access. That increases the amount of radiation. So you should try to maintain at least 50 centimeter distance from the radiation beam. Compared to the first operator, second operator is less exposed to radiation because partly the second operator is covered by the first operator, and also is at a further distance. Other staff is exposed to lesser amount of radiation. So you should also have a movable over table shield and a curtain shield under the table. Right. And if you have steep angulations, the radiation beam will have to travel a long way through the patient's body, which increases the scatter. So you have to use views that minimize radiation exposure. I mean, when you are doing a diagnostic angiography, you have to take all the views. But if you are doing a prolonged procedure like a CTO, then try to keep the radiation view where the radiation is minimized. And AP views and RAO views are preferred to LAO views to reduce the radiation dose. In LAO views, radiation is more because radiation source is to the right of the patient or more towards the operators. So RAO views, radiation source is away from the operators. Although I say this, there are some radiographers who like LAO caudal views and LAO cranial views. And there's a thing called collimation. Collimation is where you focus the radiation beam to the required area to reduce the volume irradiated. So when the volume irradiated is less, radiation exposure is also less. And use the fluoroscopy pedal only when viewing the imaging monitor. So don't keep your foot on the pedal while you are doing something else. So fluoroscopy time should be kept to a minimum. Sometimes when there are new trainees, new operators starting their career, they may accidentally keep the foot on the pedal for a longer durations, but when you get the experience, that will be less. And you have to have your balloon or stents in your hands when you press on the fluoroscopy. Do not press fluoroscopy before you get the equipment into your hands. And most of the procedures you can use low intensity modes like frames per second. 7.5 will be enough for most thin patients. You can use higher intensity modes for patients who are very obese. Those patients need higher radiation to get clear images. And also the image receptor or the radiation detector should be kept very close to the patient's skin to reduce scatter. So collimation is when you focus the radiation on the patients only on the required area without that area will receive the radiation. Image will be also clearer. On the that green arrows is showing how collimation works. So patient has less radiation when you put the collimation. And also there is thing called shutters. If you have to use shutters to block out the white areas in the screen, so you get better image quality and there is less radiation. So always use collimation and shutters. And other few things are, you have to keep the only essential staff inside the cath lab. Keep movable radiation shields. If the cardiac physiologist needs to be in the cath lab, you can make a fully shielded place for the physiologist to avoid exposure, because physiologist does not need to do anything actively inside the cath lab other than monitoring. Also, when you ask one of the nurses to give some medication or adjust in the fluids, do not push on the pedal unless you are doing a very patient who is had a cardiac arrest. Sometimes you might have to. Otherwise, in routine cases, you should avoid pressing on the pedal when a nurse is going to give a drug to the patient. So they say the amount of radiation, there are for various radiation-related injuries, amount of radiation is different. So if the fetal toxicity, there is a separate amount. For cataract, there is a separate amount. For cancer, there is a separate amount. So what we should try to do is as low as reasonably practicable. That is so you should use as low as possible radiation, because we do not know, even slightly increased amounts also can increase the risk of malignancy. One other thing is, when the nurses get pregnant, they usually never come to the cath lab. But they have done studies. The legal dose limit for entire gestation is 5 millisieverts. But if there is a cardiac interventionalist or the first operator working in the cath lab, she will get only 0.9 millisieverts. The fetus is only get 0.9 millisieverts. So pregnancy, although we are afraid, I don't think it's really a reason for people not to come to the cath lab when they get pregnant. Maybe in the first trimester, but after that, the radiation-related effect is negligible on the fetus. When we come to the contrast-induced nephropathy, this is the impairment of renal function following administration of contrast, right? So this peaks at 3 to 5 days and resolves in 10 to 21 days. Pathophysiology is not very clearly understood. So to prevent contrast-induced nephropathy, we should first analyze the level of risk. So low-risk patients, they can have oral hydration and go ahead with the procedure. Moderate risk patients are the high-risk patients we try to not to do procedures, right? Moderate risk patients are the ones where we need to consider hydration and getting nephrologist's opinion. So if the procedure is essential for a moderate risk patient, you correct the modifiable risk factors, like you can give hydrate with isotonic saline. So you have to start at least 3 hours before the procedure and continue up to 12 hours. So they say you have to give at least 1 to 1.5 milliliters per kg. If the patient's weight is 70 kilograms, you have to give 70 ml at least per hour. You have to stop nephrotoxic drugs at least 2 days before the procedure, metformin on the day of the procedure. Serum creatinine should be checked, not immediately after the procedure, but 48 to 72 hours after the procedure. You can give high amount of normal saline, 3 ml per kg. That is about 200 ml per kg. Of course, you have to check whether the patient has good left ventricular function for the same day procedures. What we see is sometimes, especially the acute patients who come with non-ST elevation MIs, unstable angina, when they are waiting in the medical wards, they are asked not to eat and drink. So they are dehydrated. So you should not ask them to eat, and patients should be allowed to eat and drink. Even if they have a STEMI, they can eat and drink. Unless they are in heart failure, if they are in cardiogenic shock or heart failure, they can take light meals. There is no need for fasting. There are some patients who have low blood pressure or inotropes, creatinine is rising, urine output is low. Those patients, of course, you may consider keeping only oral fluids, but other patients can eat and drink. So when one of the main issues is when we get acute patients with STEMI. So you have to do the procedure urgently. We don't know the creatinine. So we don't wait for the creatinine or any other blood test for the acute interventions. So best thing is to assume the worst. You assume this patient might have CKD. So keep the acute intervention simple. So if there is a acute block of the left anterior descending artery, you open up the left anterior descending artery. Do not try to do bifurcations and very complex cases, right? And if the radiation, if the contrast dose is getting higher, if the patient has multivessel disease, you may consider opening up the infarct-related vessel and keep the other vessels for another day. You can do a stage procedure. We give N-acetylcysteine and sodium bicarbonate, but there is only very little evidence for their effectiveness. So there are many factors. Some are modifiable, some are non-modifiable. I'm not going to go into details. So you have to be really careful about patients who have diabetes and who have CKD and very elderly patients. So isosmolar solutions are preferred, like Visipec. Visipec is actually a trade name. The name is iodoxinol. Avoid high osmolar agents and keep the volume low as possible. So if there's a patient has renal impairment, you have to do the angiogram at less than 30 ml of contrast, by less than 30 ml of contrast. So you should do probably 3 shots for the left coronary and probably 1 shot for the right coronary. At the same time, you have to ensure you get adequate images also, because if the images are not clear, minimizing contrast is not useful. So they have given an equation to calculate maximum acceptable contrast dose, which is defined as 5 ml times body weight divided by baseline serum creatinine milligrams per deciliter. If the patient's creatinine is 2 milligrams per deciliter, weight is 70, this comes to 5 times 70 is 350, you have to divide it by 2. Okay, most of the patients you might be able to manage with fluids. Sometimes they might need temporary dialysis. Very rarely they might need permanent dialysis. There can be anaphylactoid reactions to contrast. We give steroids and antihistamines, but it is mainly for patients who had previous reactions to contrast. Other patients, like sometimes we see giving hydrocortisone and prednisolone to patients who had beef allergy, seafood allergy. There is their studies have shown there is no benefit. Come to the injuries. So do not override safety features. That is actually my leg got injured when we were doing a procedure by the tube. So you always inform. At that instance, of course, I was informed, but I still didn't take my leg. So you have to inform when moving the bed or C-arm. And other thing is, when the patient is confused and agitated, patient might fall from the table. So somebody has to be with the patient all the time. So there can be medication errors. Emergencies are more likely to cause errors. When doctor asks you to give GTN or something, the nurse who is giving has to repeat the order and double check labels with another member of the staff. Keep calm. All this happens usually in emergencies. And do not make the staff agitated. They are more likely to cause errors. So keep these things labeled. And cardiac cath lab procedures is a teamwork. You have to help each other and build up the team spirit. So you can keep the staff happy. You can get better procedures, better communication. Of course, that is not me in that photo. It's other cardiologist in Anuradhapura. Thank you.
Thank you, Sunit, for the practical lecture.